Welcome to Module 4, Strategies for Successful Implementation. This was developed by Jennifer Moore, Kirsten Potter, and Jennifer Pyatt. In previous modules of this training program, we described what outcome measures are and why it's important to use quantitative measures in practice. We also discussed the various psychometric properties that are important to consider when selecting measures. In this module, we're going to discuss feasible ways to incorporate measures in clinical practice and how you, as a student, can facilitate positive change in a clinical practice. Our objectives for this session include: describe the need for outcome planning, describe the benefits and challenges with using outcome measures in clinical practice, identify strategies to facilitate the use of outcome measures in clinical practice, identify strategies to overcome challenges to implementing outcome measurement in clinical practice, and finally, effectively sustain outcome measurement used across his or her practice and across practice sites or programs. Outcomes measures assist clinicians with identifying areas of impairment, activity limitations, and participation restrictions, which become the focus of rehabilitation interventions in all settings and programs. Using appropriate outcome measures before, during, and after therapy episodes helps clinicians understand whether the current treatment plan is working or if a different course of treatment should be initiated. Specific outcome measures characteristics identified that substantially improve clinical decision-making. For example, outcome measures can provide clinicians with information such as the required amount of change that indicates a meaningful change, normative values that allow clinicians to compare scores to individuals without disabilities, cutoff scores that help clinicians classify patients into groups such as high fall risk or versus low fall risk. Despite these benefits, outcome measures are infrequently used to inform clinical practice. In addition to benefits to clinicians and patients, there are also many benefits of using outcome measurement to organizations. These include increased accountability, which provides mechanism to compare clinician outcomes. It provides a way to understand patient outcomes and ensure quality of care. It improves the efficiency of clinicians. It standardizes the delivery of care. It helps to focus interventions around specific impairments, activity limitations, and participation restrictions. And it improves care and outcomes of clinical care. Using standardized assessments provide feedback to the clinician about progress and when interventions should be altered or if a patient should be discharged. It also provides an organization with information about the outcome of the episode of care and methods to compare to other organizations. The need for outcome planning. Outcome measures are now required by CMS, CARF, and the Affordable Care Act. This reinforces the policy rationale for use of outcome measures, including the Centers for Medicare and Medicaid Services, which is the funded expansion of home and community-based waiver and other programs in states to provide needed services and support to transition to or remain in the least restrictive and really cost-effective community-based rehabilitation settings and to prevent or delay nursing home or institutional placement. These supports include equitable access to needed therapy services, assistive technology, or home modifications such as personal attendance and other modifications. The Commission on Accreditation of Rehabilitation Facilities, typically referred to as CARF, requires that therapists address and document participation for any facility applying for stroke specialty programs, stating that intervention should focus on community integration and participation in life roles. The Affordable Care Act of 2010 further highlights the provisions of community-based rehabilitation services and support to people with disabilities and older Americans, particularly for those who would otherwise not qualify or be able to afford such services. For more details, you can go to www.healthcare.gov. Most importantly, the client-patient benefit from understanding the results of the outcome measurement. Specifically, they understand any improvements that were made. In two separate studies, patients who received specific improvements of test results demonstrated better outcomes. In the Shiro trials, all patients performed a gait speed test. Those who were given feedback on the results of the gait speed test demonstrated more improvements in gait speed than those who did not have feedback. In the Lens article, older adults were randomized into an enhanced medical rehabilitation group that included frequent feedback to patients on their progress. The group that received this enhanced rehabilitation showed higher intensity therapy, more engagement in therapy sessions, improved gait speed, and 6-minute walk distance when compared to those who received standard rehabilitation. Although standardized outcome measures are being used by some clinicians, this practice of utilizing standardized outcome measures has not been fully adapted in rehabilitation across various therapies. For example, 52% of physical therapists reported not using standardized assessments. 49% of these indicated no future plans whatsoever to use standardized assessments. Mental health practitioners utilize their own intuition more than standardized measures to monitor progress and to make decisions based on the therapies provided. Oncologists rely more on their own impressions and informal assessments to make medical decisions. Nurses rely on clinical judgment to manage patients. There are many reasons why the utilization of standardized outcome measures has occurred on individual and organizational basis. Some facilitators that use these outcome measures include the reasons is provide positive feedback, including an openness to measurement and change and being convinced of the benefits of doing so. Flexibility. There's room for personal consideration. And practicality. Outcome measures provide quantitative data to better enable clinicians to negotiate with insurers, and they also assist with the facility's quality improvement efforts. Many external resources are available and can assist clinicians with using measures in practice by providing ways to overcome common challenges. Some examples of these resources include concisely summarized research, support from colleagues, and guidance in selection, administration, and interpretation. There are many reasons standardized outcome measures are not used routinely in clinical practice, and there's some common challenges across the various different disciplines. These relate to both the individual clinician and the broader organization. When trying to make a positive change in practice, one must first identify the challenge. We previously mentioned that clinicians do not use outcome measures to inform their clinical decisions. This slide goes a step further to outline multiple barriers and facilitators to using measures in practice. Some common barriers have been identified in the literature, including the time it takes to search for a new outcome measure, learning how to use it, the knowledge to select the most appropriate outcome measure, equipment available to facilitate the standardized assessment, and possibly even individuals such as opinion leaders who may be resistant to change. Other challenges stem from the organization itself. Some common barriers in healthcare organizations pertain to time and cost, and ultimately the culture of the organization that you may be working in. Despite the many challenges to using measures in practice, there's some very simple strategies that can be used to enhance their use to increase the success of utilization of standardized measures. As you will see, many of these strategies can be accomplished by students during their clinical experience. Some of these examples are listed on this slide. First of all, documentation. There's available test packets of all routine tests in the clinic. Recording results. Paper. Create a testing form that includes all tests performed regularly. Or electronic. Designate a specific place to record test results in the record. Or you can also create cheat sheets with meaningful change scores. As far as equipment, you could designate a specific area for testing. You could change the tile color, designate wall makers to indicate specific distances if you're doing specific tests on how far someone has walked or moved. You can create testing kits for common outcome measures. The utilization possibly of assistive technology. And then also another solution to these clinical challenges is the time to administer. You can create checklists for each patient to ensure all measures are taken, or you could even determine when an assessment could be included during a treatment session. This slide presents several more ideas for how to overcome the barriers to using measures in practice. There are many ways that you can continue to learn about measurement and other ideas that you can implement yourself to affect change during your clinical experience. These will help you as well as your future colleagues overcome some common barriers. These include developing in-services, staff sharing measurement instruments, share outcome measurement data at team meetings. You could start a brown bag outcome meeting, as well as sharing with various disciplines so there's not unnecessary duplication of testing. In addition, we want to talk about that there's many free online resources that are available to provide information about outcome measures. Several of these are listed and described in the next few slides I'm going to show you. Additional resources can be found at www.rehabmeasures.org on the links page. Let's look at Rehab Measures Database and the APTA Neurology Section EDGE recommendations. These two resources provide information to assist with the selection, administration, and interpretation of outcome measures for a wide variety of patient populations and disciplines. The Rehabilitation Measures Database, which was developed by RIC, CROR, includes summaries of the psychometric properties and clinical utility of nearly all different types of outcome measurements. The American Physical Therapy Association Neurology Section has reviewed measures for patients with stroke, MS, TBI, SCI, PD, and vestibular disorders and have provided recommendations for use in clinical practice. Recommendations were also made for each measure's use in research and the education of entry-level DPT students. Although this was developed by physical therapists, their outcome measure reviews and recommendations may be of interest and use to clinicians in other disciplines, including occupational therapy, recreational therapy, and speech therapy. There is a collaborative effort, we finally want to talk about there is a collaborative effort between RIC, CROR, and the APTA Neurology Section to integrate information on rehabmeasures.org. Here are two other online resources that focus on the use of measures for specific populations. The first one is the Stroke Engine Assess, which provides outcome measures whenever possible and psychometric and clinical utility information. The second one is Evidence-Based Review of Stroke Rehabilitation, which of course is specific to individuals with stroke. These two resources listed above provide information specific to outcome measures for patients with stroke. The next two resources listed on this slide, the Center for Outcome Measurement and Brain Injury and Acquired Brain Injury Evidence-Based Review, provide information specific to outcome measures for patients, of course, with brain injury. Now here are some additional sites that may be of assistance to you as well, depending on the population in which you treat. The Spinal Cord Injury Rehabilitation Evidence, SCIRE, is another disease-specific resource that's available to you as a student as well as a clinician within the field. Other website descriptions with links are available at the Rehabilitation Measures database that we've talked about previously. Okay, in this section we will describe a variety of activities that can be completed in the classroom environment. Many of these can be adapted for use in a clinical environment as well and could be facilitated by a student during a clinical experience. There are 5 suggested classroom activities. Each one of these is described in the following slides. The first one is discussion of need for standardized outcome measures. The second one is develop a presentation on measurement, similar to an in-service. You can adapt, the third one is adapting an evidence-based summary to meet your clinical needs. The fourth is to develop a resource binder. And the fifth is to discuss responses to common reaction to measurement utilization. As instructors, you should please determine which ones might be most applicable to your students, and as students, consider which of these you might feel capable of using in the clinic. This might give you a great idea for an in-service or project to complete during your clinical or internship experience. Okay, classroom activity 1 is you can discuss the benefits of using outcome measures at each one of these levels: patient, clinician, and organizational process. Using the ICF worksheet to prepare an initial outcome plan with the two assessments in each category would be very beneficial. This could be done as an interdisciplinary activity, or the measures could be done by different team members. Classroom activity number 2 is developing a presentation with your classmates that you could share at your clinical site. Listed on this slide are some suggestions for what you could do, but are not all inclusive. So you can review available outcome measures of the online resources that have been presented in this online presentation. You could also talk about the fundamentals of measurement, discussing reliability, validity, incidences of change. Or you could even present a case description where you use a measurement instrument in a hypothetical case, describing proposed measures, standardized assessments that are appropriate, and what potential clinical outcomes you may be looking at. Now, students are also well positioned to summarize and adapt information from various online resources. Several of the colleagues, clinicians that you are working with may not be familiar with some of the information we've shared in this presentation. You can download content from the website, share your summaries with staff during your clinical experiences, and how they might use the information that you've given them. This is an example of how an existing summary on one of these databases could be adapted to meet your needs. This information was extracted from the Rehabilitation Measures database. You can see that it briefly describes the psychometric properties and clinical utility of an outcome measure. Key pieces of information when selecting and interpreting outcome measures. Here's some class activities that might be facilitated. You could discuss the components of measurement that may be beneficial to summarize for clinicians, and what components of measurement would clinicians refer to frequently to set goals and understand progress. Now, this summary could be adapted to include the information that refers to a population of patients that you see in the clinic and the measure's reliability, validity, and incidences of change. You could also include specific considerations for your clinical site, such as when to administer the measure and where or how to document the information of the patient's medical record. In addition, site-specific information could also be added, including where the equipment is kept, where is the specific testing area, and how can the information gained be appropriately used in goal writing and documentation on various patients. As a student, you could work with your clinical instructor to determine how to best adopt these summaries. They could be combined into a binder as a resource for the staff. Additionally, you could do an in-service on how to interpret the information included. Classroom activity 4 is developing a resource binder. So what is a resource binder? It would include developing one-page summaries where you may potentially look at the archives of physical medicine and rehabilitation. This journal now publishes a summary sheet for a given measure in each issue of the journal. These may be found at www.archives/pmr.org. Students could develop similar summaries for use in clinical practice. Now that we've described various classroom activities, let's talk about how you would respond to maybe some of the following comments that you receive from people of why they don't do outcome measurements. The comments noted above are often heard in clinical environments and reflect some of the barriers to using measures that we previously discussed. Both students and instructors should be well positioned now to think about how we might want to respond to these type of comments. Now that you've completed this course, use the following discussion questions to reflect on your learning across the 4 modules. What is the value of using the ICF to organize your clinical measures? Why is it critical to use a client-centered approach? Why should you use valid and reliable measures? How can you interpret change and know that the patient has a meaningful improvement? What strategies could you use to introduce measures into your practice? And what can you do to overcome barriers you will find in developing an outcome measurement plan at your clinical site? In wrapping up this presentation, we do want to list all of the project staff that were included in developing the modules that you have been presented. In addition, here are the project contributors as well as references for Module 4. And finally, copyright information. All of this information is the property of the Rehabilitation Institute of Chicago. You are free to copy, distribute, and transmit the work subject to the conditions listed in the license. For permission to modify this work or to use it for commercial purposes, please email Alan Heineman at aheineman@ric.org. Thank you so much, and I hope this information was beneficial.